Alrighty, guys, welcome to one more podcast. Today we're talking about kidneys, urinary tract, and arterial blood gases. As you know, I usually like to mix subjects. Okay, ChatGPT, let's get it on.
Sounds good. So, are we starting with a quick overview of kidney function or jumping right into arterial blood gases?
I would like to jump in with what is the urinary tract.
Great choice. The urinary tract includes the kidneys, ureters, bladder, and urethra. It's responsible for removing waste and extra fluid from the body. The kidneys filter blood, creating urine, which travels down the ureters to the bladder, and then it's excreted through the urethra.
That makes sense.
Glad it does. Anything specific about the urinary tract you want to dive into?
Yeah, what are the suprarenal glands? Are these part of it?
Yes, the suprarenal glands, also known as adrenal glands, sit on top of the kidneys. They aren't part of the urinary tract, but are crucial for hormone production, like adrenaline and cortisol, which help regulate metabolism, immune response, and stress.
Tell me one more time.
Sure. The adrenal glands, or suprarenal glands, are located on top of each kidney. They produce hormones like adrenaline, which helps with stress responses, and cortisol, which regulates metabolism and immune function.
And what is this supra in front?
Supra means above, so suprarenal literally means above the kidney. It refers to the gland's position right on top of each kidney.
So are they part or not part of the urinary tract?
Exactly. They're not part of the urinary tract. They're part of the endocrine system, which manages hormones.
What is renal?
Renal refers to anything related to the kidneys, so renal means kidney related.
What about the retroperitoneal? What is this? Sir, what is retroperitoneal? It's getting shy, guys. I'll keep you busy until our guest comes back. So I guess retroperitoneal, guys. Sir, what is retroperitoneal?
Hey, so the retroperitoneum is an anatomical space in your abdomen. It's located behind the peritoneum, which is the lining of the abdominal cavity. Organs like the kidneys, pancreas, and parts of the aorta are found there. It's a bit like a hidden compartment behind your main abdominal organs.
And what is the function of the urinary bladder?
The urinary bladder's main function is to store urine produced by the kidneys until it's ready to be expelled from the body. It acts like a reservoir, expanding as it fills, and then contracts to push the urine out through the urethra when you go to the bathroom.
And the ureter comes before it?
Yup, the ureters are the tubes that carry urine from the kidneys down to the bladder. They transport urine using peristaltic movements, which are wave-like muscle contractions. Each kidney has one ureter that connects it to the bladder.
Interesting.
Yeah, the whole urinary system is pretty fascinating. It's like a well-organized plumbing system in your body. Anything specific you'd like to dive into? Sure. Intraperitoneal organs are those completely surrounded by the peritoneum, a membrane lining the abdominal cavity. Examples include the stomach, liver, spleen, and parts of the intestines, like the jejunum and ileum. These organs are mobile within the abdominal cavity.
Okay, and what are peritoneal pouches?
Peritoneal pouches are recesses or spaces formed by folds of the peritoneum. For instance, the rectouterine pouch, also called the pouch of Douglas, is between the uterus and rectum in females. Another example is the vesicouterine pouch between the bladder and uterus. In males, the rectovesical...
Rectouterine and vesicouterine?
Exactly, those are two key examples. The rectouterine pouch is the space between the rectum can collect fluid or other substances in certain medical conditions.
Okay, we have to talk about the etymology of vesicouterine, rectouterine. What is all of this? And, okay, yeah.
Sure, etymology-wise, vesico comes from the Latin vesica, meaning bladder. Uterine refers to the uterus. So vesicouterine means the space between the bladder and uterus. Recto comes from the Latin rectus, meaning straight, referring to the rectum. So rectouterine means the space between the rectum and uterus.
Okay. So, what is vesico?
Vesico specifically refers to something related to the bladder. It's often used in medical terms to describe structures or spaces involving the bladder, like vesicouterine, indicating the area between the bladder and uterus.
And what about when we're supine? What's the most inferior part of the peritoneal cavity?
When supine, the most inferior part of the peritoneal cavity is the rectouterine pouch in females and the rectovesical pouch in males. These pouches are the lowest points where fluid or pus might collect.
Tell me again.
No problem. When lying on your back, the lowest part of the peritoneal cavity is the rectouterine pouch in females and the rectovesical pouch in males. These are the spots where fluid can pool.
And why this difference?
The difference is due to anatomical variations. In females, the rectouterine pouch is formed between the rectum and uterus. In males, there's no uterus, so the lowest point is the rectovesical pouch between the rectum and bladder.
Okay.
Glad that helped.
Rectovesical. So we have uterine, we have vesicouterine, we have rectovesical too.
Exactly. Each term describes a specific pouch based on anatomical relationships. Rectouterine for rectum and uterus, vesicouterine for bladder and uterus, and rectovesical for rectum and bladder.
Okay, let's talk a bit about the location of the kidneys, but let's go slightly more in detail. So, what rib are we talking about?
Sure. The kidneys are located in the retroperitoneal space, meaning they're behind the peritoneum. They sit on either side of the spine, usually between the T12 and L3 vertebrae. The right kidney is slightly lower than the left due to the liver. They're also protected by the lower ribs.
I was going to ask, so why is the superior pole of the left kidney the 11th, 12th, but the superior pole of the right kidney is 12? I guess because left side has the heart, so it's a bit... Actually, no, that will make sense. Wait, which side even has the heart?
The heart is actually on the left side, but it doesn't affect the kidney's position. The left kidney is higher because there's more space on that side. The right kidney is lower since the liver, which is large, sits above it. So the superior pole of the left kidney aligns with the 11th rib, while the right kidney is slightly lower around the 12th.
Oh, interesting.
Yeah, it's pretty cool how the organs fit together.
Okay. And let's talk a bit about some structures. So, each kidney moves during respiration too. I don't understand why.
Great observation. The kidneys move with respiration because they're retroperitoneal and loosely attached. When you inhale, the diaphragm contracts and moves downward, pushing abdominal organs, including the kidneys, slightly downward. This movement is normal and helps with circulation and organ function.
And we have the diaphragm and the psoas major, quadratus lumborum, and transversus abdominis. Tell me about all of this. Transversus abdominis is in the abs.
Exactly. The transversus abdominis is the deepest abdominal muscle, wrapping around the sides. The diaphragm is a dome-shaped muscle under your lungs, crucial for breathing. The psoas major is a long muscle running from the lumbar spine to the femur, important for hip flexion.
So, are these structures that I told you, how are they related to the kidneys?
All these structures are closely related to the kidneys. The diaphragm sits above the kidneys, influencing their movement during respiration. The psoas major runs along the inner side of each kidney, and the quadratus lumborum is just behind them. The transversus abdominis provides a layer of support in front. All these muscles play roles in stabilizing and protecting the kidneys.
What even is this psoas major?
The psoas major is a long, thick muscle that runs from the lumbar spine down to the femur. It's a key muscle for hip flexion, meaning it helps lift your thigh toward your body. It's also involved in stabilizing the spine and pelvis.
And what's the reason that nature, evolution, God, whatever you want to say, put these in this place? And don't give me a generic answer such as it was the most efficient method. Explain to me why it's the most efficient method.
Sure, the psoas major's placement is strategic for several reasons. First, its origin at the lumbar spine and insertion at the femur allow it to efficiently flex the hip. This placement also helps stabilize the lumbar spine, crucial for posture and movement. Additionally, its position near the spine and pelvis provides mechanical leverage.
What even is psoas major? Why psoas? Is this what kind of word is this?
Psoas comes from the Greek word psoa, meaning loin. It's named for its location in the lumbar region, near the loins.
What is
This
loin?
muscle's function. Loin refers to the area on the sides of the spine, between the lower ribs and the pelvis. It's often used to describe the lower back or the region around the kidneys.
Okay, and what's the quadratus lumborum?
The quadratus lumborum is a quadrilateral shaped muscle in the lower back. It spans from the iliac crest to the 12th rib and lumbar vertebrae. It's crucial for stabilizing the spine and assisting in lateral flexion, meaning it helps you bend sideways.
Tell me more about this.
Sure, the quadratus lumborum QL is a deep back muscle. It helps stabilize the pelvis and spine, especially when you stand or walk. It also aids in lateral flexion, allowing you to bend your torso to the side. Additionally, it plays a role in stabilizing the 12th rib during respiration.
Interesting. Okay, let's talk now a bit about kidneys coverings.
All right, the kidneys have three main coverings. The innermost is the renal capsule, a tough, fibrous layer directly surrounding each kidney. Outside that is a layer of perirenal fat, which cushions and protects the kidney. The outermost layer is the renal fascia, which anchors the kidneys to surrounding structures and the abdominal wall.
So we have the renal capsule and then we have the perinephric fat.
Exactly. The renal capsule is the tough, protective layer directly covering the kidney. The perinephric fat surrounds the renal capsule, providing cushioning and insulation.
And okay, so what is the function of these two?
The renal capsule protects the kidney from trauma and infection. The perinephric fat acts as a cushion, shielding the kidney from physical shocks and helping maintain its position.
And then, before you answer, guys, this is not an accurate diagram, just so you know. Okay, tell me.
No worries. The renal fascia, the outermost layer, anchors the kidneys and keeps them in place within the abdomen. It also separates the perinephric fat from the surrounding tissues.
What's fascia?
Fascia is a sheet of connective tissue that surrounds and supports muscles, organs, and other structures. It provides structure, protection, and support, and also separate different tissue layers.
And how does the renal fascia condensate? Condense? I don't know what the right word is. The areolar connective tissue. What even is areolar?
Areolar connective tissue is a loose, fibrous tissue with a gel-like matrix. It fills spaces between structures, providing cushioning and support. The renal fascia condenses this tissue around the kidney, forming a tough layer that anchors the kidney in place.
Tell me again.
Areolar connective tissue is a loose, fibrous tissue with a gel-like matrix. It fills spaces between structures, providing cushioning and support. The renal fascia condenses this tissue around the kidney, forming a tough layer that anchors the kidney in place.
Sir, I'm confused.
No problem. Areolar connective tissue is a soft, flexible tissue that fills spaces and provides support. The renal fascia uses this tissue to form a strong layer around the kidney, keeping it stable.
What about the transversalis fascia and the fascia over the diaphragm? Are these the same thing?
The transversalis fascia and the fascia of the diaphragm are not the same. The transversalis fascia lines the abdominal wall, while the diaphragm has its own fascia. They connect, forming a continuous layer supporting the abdominal cavity. It's a bit complex, but they work together to support your organs.
Perinephric, and the renal capsule, and the renal fascia. Alright.
Exactly. Those are the main layers protecting the kidneys.
And we also have paranephric fat. What's the difference of that?
Paranephric fat lies outside the renal fascia, providing additional cushioning and insulation.
So what's the difference between peri and para?
Peri means around or near, so perinephric fat is right around the kidney. Para means beside or alongside, so perinephric fat is next to the renal fascia, outside of the perinephric fat.
Alright, let's go to our arterial blood gases now. So, I think, I want to ask you, what's volatile acid and why is CO2 a volatile acid?
A volatile acid is one that can be exhaled through the lungs. CO2 is considered a volatile acid because it dissolves in blood, forming carbonic acid. This carbonic acid can then dissociate into hydrogen ions and bicarbonate. The CO2 is expelled through breathing, regulating blood pH. A volatile acid is one that can be exhaled as a gas. CO2 is considered a volatile acid because it can be converted to carbonic acid in the blood.
You know what I want to ask, guys. Have you guessed? What's a non-volatile acid then, since CO2 is a volatile acid? Oh, guys, we're losing him. It's gonna die. So, what's a non-volatile acid since CO2 is a volatile acid?
Non-volatile acids, also known as fixed acids, are acids that do not evaporate easily. Examples include sulfuric acid and phosphoric acid. They typically result from the metabolism of proteins and are excreted by the kidneys.
I'm confused.
No worries. Basically, non-volatile acids are acids that your body can't get rid of through breathing, like CO2. Instead, they're handled by your kidneys. Examples are sulfuric acid and phosphoric acid, which come from breaking down proteins.
So volatile, it means we can get rid of them?
Exactly. Volatile acids like carbonic acid can be expelled through the lungs as CO2. Non-volatile acids, on the other hand, need to be processed by the kidneys.
Okay. That makes sense. Okay. Well, I'm gonna go straight into the main food, if you'd like to call it food. What's respiratory acidosis?
Respiratory acidosis happens when your lungs can't remove enough CO2, causing it to build up in your blood. This leads to a drop in blood pH, making it more acidic. It's usually due to conditions that affect breathing, like COPD or severe asthma.
So we have retention of CO2.
Exactly. That CO2 retention is what causes the blood to become more acidic, leading to respiratory acidosis.
And what's fixed acids?
Fixed acids, or non-volatile acids, are acids that can't be exhaled through the lungs. They're produced from sources like protein metabolism and must be eliminated by the kidneys. Examples include sulfuric acid and phosphoric acid.
Tell me more.
Sure, Fixed acids are byproducts of metabolism that can't be converted to a gas. The body produces them mainly from breaking down amino acids and nucleic acids. Since they can't be exhaled, the kidneys filter them out, maintaining acid-base balance.
So it's the same thing as non-volatile?
Exactly. Fixed acids and non-volatile acids are just two terms for the same thing.
Alright, so ChatGPT is fixed acids the same as volatile acids? Sorry guys, I went to the toilet and came back.
No worries. To clarify, fixed acids and volatile acids are different. Fixed
Sorry.
acids can be exhaled.
Non-volatile and fixed.
Got it. Yes, non-volatile acids and fixed acids are the same thing.
Okay, what about metabolic acidosis? How does it differ from respiratory acidosis?
Metabolic acidosis is caused by an excess of fixed acids or a loss of bicarbonate, often due to kidney issues or conditions like diabetic ketoacidosis.
Tell me again the reasons.
Sure. Metabolic acidosis is from excess fixed acids or bicarbonate loss, often due to kidney problems or diabetic ketoacidosis. Respiratory acidosis is due to CO2 buildup from impaired lung function.
Bicarbonate, HCO3 minus.
Exactly. Bicarbonate, or HCO3 minus, acts as a buffer. When it's lost, it can lead to metabolic acidosis because there's less buffering capacity for acids.
Phosphate is also a buffer.
Yes, phosphate also acts as a buffer, especially in the kidneys. It helps neutralize acids and maintain the body's pH balance.
And why is phosphate a buffer? Don't tell me because it's an efficient and effective molecule. Answer to me deeply, please.
Sure. Phosphate acts as a buffer because it can exist in multiple forms, like dihydrogen phosphate and hydrogen phosphate, which can donate or accept hydrogen ions. This ability helps stabilize pH by neutralizing excess acids or bases, especially in the intracellular environment.
Tell me again.
Certainly. Phosphate works as a buffer because it can switch between forms that either release or absorb hydrogen ions. This helps maintain a stable pH by counteracting changes in acidity, especially inside cells and in the kidneys.
So how do fixed acids get eliminated by the kidneys?
The kidneys eliminate fixed acids through several steps. They filter blood, secrete hydrogen ions into urine, and reabsorb bicarbonate to neutralize acid. This process ensures the body's acid-base balance is maintained.
That makes sense. So let me ask you another question. So how do we detect an abnormal accumulation of fixed acids?
We detect abnormal accumulation of fixed acids through blood tests, specifically measuring the pH and bicarbonate levels. An arterial blood gas test is commonly used to assess these values and determine if there's acidosis.
What is this test?
It's called an arterial blood gas, or ABG test. It measures the pH, partial pressures of oxygen and carbon dioxide, and bicarbonate levels in the blood. This helps assess lung function and detect acid-base imbalances.
What's the gold mark acronym?
The GOLD acronym stands for Global Initiative.
No, gold mark.
Got it. GOLDMARK is an acronym used to remember causes of anion gap metabolic acidosis. It stands for glycols, oxoproline, L-lactate, D-lactate, methanol, aspirin, remodeler, and ketoacidosis.
Okay, and lactate is an important one, And can we talk a bit about lactate, renal failure, and ketoacidosis? They seem to be some of the big ones. L-lactate specifically.
Sure. L-lactate builds up when tissues don't get enough oxygen, often due to shock or intense exercise. In renal failure, the kidneys can't clear acids, raising acid levels. Ketoacidosis happens when the body breaks down fats too quickly, producing ketones, which are acidic. All these can cause metabolic acidosis.
Okay. Interesting. So
Hey?
that makes sense. So in detecting this abnormal accumulation of fixed acids, you said you use arterial blood gases, but how exactly does it work?
Sure. Arterial blood gases, or ABGs, measure the levels of oxygen, carbon dioxide, and blood pH. They help determine if there's a buildup of acids or bases, which can indicate metabolic or respiratory issues. By analyzing these values, doctors can figure out if there's an acid-base imbalance.
Interesting. Okay, let's talk about the anion gap now.
All right. The anion gap is a calculation used to identify the cause of metabolic acidosis. It's derived from the concentrations of sodium, chloride, and bicarbonate in the blood. A high anion gap suggests there are unmeasured anions present, often due to conditions like ketoacidosis, lactic acidosis, or toxin ingestion.
So would you agree that sodium with potassium and unmeasured cations should equal with chloride bicarbonate and the unmeasured anions?
Yes, exactly. That balance is crucial. The sum of measured cations, like sodium and potassium, should roughly equal the sum of measured anions, like chloride and bicarbonate, plus any unmeasured anions. When there's a gap, it signals the presence of additional substances in the blood.
And why is the number 12 kind of the number that we bounce around?
So the number 12 is often used as a reference for the normal anion gap because it's a typical value for healthy individuals. It accounts for the small difference between measured cations and anions. If the gap is significantly higher, it suggests an abnormal accumulation of unmeasured anions.
I see.
Yeah, exactly. It helps clinicians quickly assess if there's an underlying issue.
I see.
Yeah, and it's pretty straightforward once you get the hang of it.
Yeah.
Absolutely.
Can you
It's
give
just
us an
one piece of-
example then? Let's try an example.
Sure. Let's say a patient has metabolic acidosis and their anion gap is 20. This elevated gap suggests there are unmeasured anions like
No.
lactate or ketone.
I want you to give me a question, then I will figure out what type it is and all that.
Got it. All right. Let's say you have a patient with a blood pH of 7.2, bicarbonate of 10, and an anion gap of 25. What might be the cause?
Again?
All right, how about this? A patient's blood pH of 7.1, bicarbonate of 8, and an anion gap of 30. What's the likely diagnosis?
Dude, don't change the numbers. I just didn't hear you the first time. Please just...
No problem. A patient's blood pH of 7.2, bicarbonate of 10, and an anion gap of 25. What do you think could be causing this?
Okay, don't tell me the answer. Don't even give me a hint. I'm just going to tell to you about my thought process. So, we have an anion gap that's bigger. And we know that anion gap is the sodium and the unmeasured equaling the chloride and the bicarbonate with the unmeasured anions. So, now we have this score of 25. Basically, if we take the Cl and the bicarbonate on the other side, we have unmeasured, just a sec, we have unmeasured anions on the other side, minus, so Na minus Cl minus bicarbonate equals unmeasured anions minus unmeasured cations, and usually unmeasured anions minus unmeasured cations is 12. So this time it's 25. So for it to be 25, it means that we had some kind of change here. Let's think. So up to now, am I right? Just say yes or no. Don't give me a hint.
Yes, you're on the right track.
Well, if the bicarbonate increases, let's put some fake values maybe. No. So I'm just wondering, did the unmeasured cations decrease? Did the unmeasured anions increase? Or did the bicarbonate, the Cl or the Na change? Don't say it to me, I'm going to think all options.
Take your time. There's definitely a few possibilities to consider.
So let me think, guys. So we have 13 extra. Well, let's put some fake values maybe. So actually, I don't even know how to put fake values. Let's put fake values. I mean, these will make no sense. I'm not even going to use the 10 here. I just want to see. Bro, I don't have any clue. You have to help me.
No worries. With a high anion gap like 25, it suggests an increase in unmeasured anions, like lactate or ketones. This points to conditions like diabetic ketoacidosis or lactic acidosis.
Tell me again.
Sure. A high anion gap, like 25, usually indicates an increase in unmeasured anions, such as lactate in lactic acidosis or ketones in diabetic ketoacidosis.
So tell me again, because I don't understand.
No problem. A high anion gap, like 25, suggests an increase in unmeasured anions. This can happen with conditions like diabetic ketoacidosis or lactic acidosis.
Why not a decrease in unmeasured cations?
Great question. Well, a decrease in unmeasured cations could theoretically cause a high anion gap. It's usually the increase in unmeasured anions, like lactate or ketones, that drives the gap up in metabolic acidosis.
Why? Because it's the loss of bicarbonate.
Exactly. The loss of bicarbonate often accompanies an increase in acids, which are those unmeasured anions, leading to the higher anion gap.
I see. That makes sense.
Glad it does. It's all about balancing those ions.
And exactly. why not? So how would So an increase in unmeasured anions kind of will balance out the loss of bicarbonate.
Right. When you lose bicarbonate, you often see an increase in unmeasured anions, which balances the charge.
Okay, now I had an aha moment.
Awesome. Those moments are the best.
So, wait a sec then. So I know we also have a non-anion gap metabolic acidosis?
Yes, exactly. Non-anion gap metabolic acidosis happens when bicarbonate is lost, but replaced by chloride, so the anion gap stays normal.
Tell me again.
Sure, in non-anion gap metabolic acidosis, you lose bicarbonate, but it's replaced by chloride, so the anion gap remains normal.
Instead of being replaced by unmeasured anions.
Exactly. Instead of unmeasured anions, chloride levels increase, keeping the anion gap normal.
Cool. Give us a question about respiratory acidosis, like the one you gave us before then.
All right, let's say a patient has a blood pH of 7.3 and a high PaCO2. What might this suggest?
High PaCO2 and 7.3 pH. So a high pH means low concentration of hydrogen ions. And you said he has high CO2. Well, I'm just wondering, how can you have a high CO2 and low hydrogen ions?
Good question. In respiratory acidosis, high CO2 leads to an increase in hydrogen ions, lowering the pH. So a pH of 7.3 is still acidic, just not extremely low.
I thought the pH should be 7.
A normal pH is around 7.35 to 7.45. So 7.3 is still acidic.
So this makes sense. Yes. Bravo. Okay, give us more examples. Give us an example of respiratory acidosis, and if there is an example of non-anion gap respiratory acidosis, perhaps.
Sure. For respiratory acidosis, let's say a patient has a pH of 7.28 and a PaCO2 of 55. That indicates respiratory acidosis. Non-anion gap respiratory acidosis isn't a specific term because respiratory acidosis is defined by CO2 levels.
We don't have it.
Correct. Respiratory acidosis always involves high CO2. The anion gap mainly applies to metabolic conditions.
Okay.
Exactly.
So, give us another example to do of give us a difficult one to do with respiratory acidosis.
All right. Let's say a patient has a pH of 7.25 and a PaCO2 of 60. What condition does this suggest?
So, wait, let's say it again. So, we have a PaCO2 of 60, and we have a low pH, which means high CO2, high H plus. I don't know, dude. I mean respiratory acidosis.
Yes, exactly. A high PaCO2 with a low pH indicates respiratory acidosis, often due to hypoventilation.
Okay, so give us another example of numbers. Oh, we're losing it. Wake up. Okay. So, give us another example of numbers, and this time, ChatGPT, give us a difficult one, dude. I don't want the answer to be, yes, high CO2. Give us one where I have to write the equation or something.
All right, how about this? A patient presents with metabolic acidosis.
No, we said let's do a respiratory acidosis one.
Got it. For respiratory acidosis, let's say a patient's arterial blood gas shows a pH of 7.28 and a PaCO2 of 55 millimeters mercury. How would you determine if there's compensation happening?
So we have a low pH and we have a high CO2.
Exactly. That low pH and high PaCO2 indicate respiratory acidosis. Now, to check for compensation, you'd look at bicarbonate levels. If they're elevated, it suggests the kidneys are compensating.
They want to match the CO2 basically. They want to match the H plus.
Exactly. The kidneys retain bicarbonate to buffer the excess hydrogen ions from the increased CO2. This helps raise the pH back towards normal. So if you see elevated bicarbonate, that's a sign of compensation. Yeah, it's pretty fascinating how the body tries to maintain balance, right?
Yeah.
Absolutely. It's a complex system, but it works pretty efficiently.
So let's talk a bit about compensations for acid-base disturbances then.
Sure, compensation in acid-base disturbances is the body's way of trying to restore normal pH. If there's a metabolic acidosis, the respiratory system compensates by increasing ventilation to blow off CO2. Conversely, for respiratory acidosis, the kidneys increase bicarbonate reabsorption. It's all about maintaining that pH balance.
Yes, that's interesting. So I want to talk about the level of compensation. We have one where we fail too, right?
Exactly. Compensation can be complete, partial, or absent. Complete means the pH returns to normal. Partial compensation happens when the pH moves closer to normal but isn't fully corrected. And if compensation fails, there's no significant change and the imbalance persists.
Okay, that makes sense. And let's jump a bit now to respiratory center. So in the respiratory center, can we talk about the pons and the medulla and how come they're named that way?
Sure. The pons and medulla are part of the brainstem. The medulla, from the Latin for marrow, controls vital functions like breathing. The pons, meaning bridge, links different parts of the brain, including pathways that regulate breathing.
What even are they? Why are they named pons?
The pons is named for its role as a bridge in Latin because it connects various parts of the nervous system, like the cerebrum and the medulla. It plays a crucial role in relaying messages and also helps regulate breathing, sleep, and facial movements.
And how do they connect to respiratory metabolic acidosis, alkalosis, and all of that?
Great question. The pons and medulla are part of the respiratory center, which controls breathing. They adjust respiratory rate in response to changes in blood pH. In acidosis, they increase ventilation to expel CO2, reducing acidity. In alkalosis, they slow breathing to retain CO2, increasing acidity.
Interesting. Okay, what about respiratory muscles and innervation? So, for instance, we have the diaphragm and the phrenic nerves and all of that.
So, the diaphragm is the primary muscle for breathing, and it's innervated by the phrenic nerves, which originate from the cervical spinal cord. These nerves send signals to contract the diaphragm, enabling inhalation. Intercostal muscles between the ribs also help expand the chest cavity, and they're controlled by intercostal nerves.
Okay, let's go back to what we were talking about then, about the kidney and the urinary tract. So, can we talk a bit about nephroptosis?
Sure, nephroptosis, also known as floating kidney, is when the kidney drops down into the pelvis when standing. It's typically due to a lack of supporting tissues. Symptoms can include pain, especially when upright. It's often diagnosed with imaging and may require surgical intervention if symptomatic.
Okay.
Anything else about
why does the kidney fall by like at least 2 vertebrae when the patient moves from supine to standing?
It falls due to a lack of support from surrounding tissues. Normally, fat and ligaments hold the kidney in place. But if these are weakened or reduced, the kidney can move more freely. This movement is exaggerated when changing positions, like from lying down to standing up.
Alright, let's talk a bit about the internal anatomy of the kidney now.
Sure, the kidney's internal anatomy includes the cortex, medulla, pelvis. The cortex is the outer layer containing nephrons, which filter blood. The medulla has pyramids that transport urine to the renal pelvis, which collects urine before it moves to the ureter.
Tell us more. Guys, give me a second. I'm just gonna wear some clothes. I'm cold.
No worries, take your time.
Tell us more.
Alright, so the renal cortex is where filtration begins, while the medulla contains structures like the loops of Henle. These structures help concentrate urine, which then flows into the renal pelvis before exiting through the ureter.
Okay, and we have a lot of things. We have the renal sinus, the renal lobe, the renal pelvis, the hilum, the kidney. What are all of these?
Sure, the renal sinus is a cavity within the kidney that houses the renal pelvis, calyces, blood vessels, and nerves. The renal lobe consists of a pyramid and its surrounding cortex. The renal pelvis is a funnel-shaped structure that collects urine. The hilum is the entry and exit site for vessels, nerves, and the ureter.
So the renal pelvis is the exit side.
Exactly. The renal pelvis collects urine from the calyces and channels it into the ureter, which then carries it to the bladder for storage.
And what about the hilum of the kidney? Is where we have the vein and arteries.
That's right. The hilum is where the renal artery enters, and the renal vein and ureter exit the kidney. It's a crucial point for the passage of blood vessels, nerves, and lymphatics.
Explain us the renal sinus again.
Sure. The renal sinus is a cavity within the kidney that contains the renal pelvis, calyces, blood vessels, nerves, and fat. It's essentially the space within the kidney that houses these structures.
Why do we call it sinus?
The term sinus in anatomy often refers to a cavity or hollow space within a structure. In the kidney, the renal sinus is the hollow chamber that holds important structures like the renal pelvis and vessels.
Can you tell me a bit more?
Absolutely. The renal sinus is surrounded by kidney tissue and contains fat that helps protect and support the structures within. It's like a central hub for the kidney's internal components.
I don't get it.
No worries. Think of the renal sinus as a central cavity inside the kidney. It's filled with fat and houses the renal pelvis, blood vessels, and nerves.
Okay, so
acting
what's the
as a-
difference between the pyramid and the renal lobe?
A renal pyramid is a triangular section in the medulla that transports urine. A renal lobe includes a pyramid and its overlying cortex, plus part of the surrounding tissue. So a lobe is a larger functional unit that includes a pyramid.
Okay, and what about the renal columns and the renal cortex?
Renal columns are extensions of the renal cortex that sit between the pyramids. They provide support and house blood vessels. The renal cortex is the outer part of the kidney, where filtration occurs and contains glomeruli and convoluted tubules.
I'm a bit confused.
No problem. Picture the renal cortex as the outer layer. The renal columns are like bands of this cortex that dig down between the pyramids, which are found in the medulla.
So
Both
the renal
structures
lobe is basically the renal cortex close to a pyramid plus the pyramid.
Exactly. A renal lobe includes a pyramid, its overlying cortex, and part of the adjacent renal columns. It's a functional unit within the kidney.
Okay, that makes sense. And what about the renal columns? Are they in between? And the renal papilla?
Yes, renal columns are between the pyramids, extending from the cortex inward. The renal papilla is the tip of each pyramid, where urine is released into the minor calyx.
Yeah, what's this minor calyx and major calyx?
The minor calyces are small chambers collect urine from the renal papillae. These then merge into larger chambers called major calyces, which funnel the urine into the renal pelvis before it moves to the ureter.
Tell me more about this. Tell me more about the renal papilla, the minor calyx, and the major.
Sure. The renal papilla is where the filtered urine exits the pyramids into the minor calyces. Each minor calyx collects urine from a single papilla. These minor calyces then join to form major calyces, which channel the urine into the renal pelvis. It's a neat system that ensures
Alright,
urine.
guys, after a long, shameless break, I'm back. So, ChatGPT, let's kick off where we were. Minor and major calyx and renal papilla, what are these?
Hey, welcome back. Minor and major calyxes are parts of the kidney. The minor calyxes collect urine from the renal papillae, which are the tips of the renal pyramids. Then the minor calyxes merge to form major calyxes, which further funnel urine into the renal pelvis before it heads to the ureter.
I'm still a bit confused as to how they connect, to be honest. I know you just said it. Could you perhaps tell more?
Sure. Picture the kidney like a funnel system. Urine first drains from tiny ducts into the minor calyxes, which are like small cups. These minor calyxes then combine to form larger major calyxes. Finally, these major calyxes join to create the renal pelvis, which leads to the ureter.
So
Does that
minor,
help?
a lot of minors make a major, and then the major makes a pelvis.
Exactly. The minor calyxes are like small tributaries, and when they merge, they form major calyxes. Then those major calyxes combine to form the renal pelvis, which channels urine into the ureter. So it's a gradual collection process.
Okay, that makes a lot more sense.
Great. Glad it's clearer now. Anything else you'd like to dive into?
Remind me what no, I remember. We talked about the renal helium too, and we have lymph vessels and sympathetic fibers there too. But what lymph vessels do we have?
The renal hilum is where structures like the renal artery, vein, and ureter enter and exit the kidney. Lymph vessels here typically drain into the lumbar lymph nodes, also known as para-aortic lymph nodes. They help carry waste and immune cells from the kidney area.
Okay.
Awesome.
And okay, and let's talk a bit about kidney development now.
Sure. Kidney development starts early in the embryo from three structures: the pronephros, mesonephros, and metanephros. The metanephros eventually becomes the permanent kidney. It starts forming around the 5th week and continues to develop through interactions between the ureteric bud and metanephric mesenchyme. By birth,
And does it develop in the pelvis initially?
Exactly. The kidneys initially form in the pelvic region. As the embryo grows, they gradually ascend to their final position in the upper abdomen.
But why in the pelvis? This is so weird. Sir.
Yeah.
So why in the pelvis? It's so weird.
It might seem odd, but it's part of the natural developmental process. The kidneys start low in the pelvis and then move up as the embryo elongates. This ascent is crucial for them to connect with the blood supply and settle into their final spot.
Interesting. Can we talk a bit about the growth and the straightening of lumbar and sacral spines?
Absolutely. As the embryo develops, the lumbar and sacral regions of the spine elongate and straighten. This process helps the kidneys move up from the pelvis to the abdomen. The spine's growth also supports the body's overall structure, providing a stable framework for other organs and tissues.
What are lumbar and sacral spines?
The lumbar lumbar spine is the lower back region of your spine made up of 5 fused vertebrae forming the sacrum, which connects to the pelvis. These regions provide support, flexibility, and protection for the spinal cord.
Tell me more.
Sure. The lumbar vertebrae are larger and sturdier because they bear most of the body's weight. They're responsible for movements like bending and twisting. The sacral vertebrae, fused into the sacrum,
What
form
is
the back wall of the...
Wait, what even is lumbar and sacrum? Can you give me the etymology, the historical origin of the wern, and blah blah blah?
Sure. Lumbar comes from the Latin word lumbus, meaning loin or lower back. Sacrum is from the Latin os sacrum, meaning sacred bone, because it was once believed to be the seat of the soul. The sacrum is also connected to ancient sacrificial practices.
And where exactly is the sacrum? I still don't get it.
The sacrum is a triangular-shaped bone at the base of the spine, just below the lumbar vertebrae. It's formed by the fusion of 5 sacral vertebrae and connects the spine to the pelvis.
Got it.
It plays
Got it. So could we talk a bit about the ectopic kidney means that it's in the pelvis? Hey dude,
Hey, what's up?
I just asked you a question about the ectopic kidney.
Sure, go ahead.
Well, what is it?
An ectopic kidney is when one or both kidneys are in an abnormal position. Instead of moving to their usual spot in the upper abdomen, they might stay in the pelvis or even cross over to the other side.
And what about hydronephrosis?
Hydronephrosis happens when urine can't drain properly from the kidney, causing it to swell. It can result from a blockage or reflux, and may lead to pain, infections, or kidney damage if untreated.
And what is it exactly?
Hydronephrosis is the swelling of a kidney due to a buildup of urine. This occurs when there's a blockage or obstruction preventing urine from flowing out, which causes the kidney to expand.
Interesting. Can we talk about some other anomalies like unilateral double kidney?
Sure. A unilateral double kidney is when one side has 2 kidneys, either partially or completely fused. This can happen due to abnormal development and may sometimes function normally. But it can also come with complications like urinary tract infections or kidney stones.
And what about the horseshoe kidney?
A horseshoe kidney is when the 2 kidneys fuse at the lower end, forming a U shape. This fusion usually occurs during development and can cause the kidneys to be located lower in the abdomen. It might function normally, but can be associated with an increased risk of kidney problems.
And we have a rosette kidney, what's that? And an aberrant renal artery causing urinary obstruction. Wow, we have so many problems.
Yeah, an aberrant renal artery is an extra or unusual artery supplying the kidney. It can sometimes compress the ureter, causing obstruction. While these anomalies can be problematic, many are manageable with medical or surgical interventions.
Interesting.
Yeah, it's fascinating how much variation there can be in kidney development.
Alright, let's go back to suprarenal glands and tell me what they do and their location, and talk to me a bit about the yellow cortex and the brown medulla. Please?
Absolutely. The adrenal glands have 2 parts, the outer cortex and inner medulla. The cortex produces hormones like cortisol for stress response, aldosterone for blood pressure, and androgens. The medulla makes adrenaline and noradrenaline, which handle fight or flight responses.
Well, what's the yellow cortex and what's the brown medulla?
The cortex appears yellow because it's rich in lipids, which are used to produce steroid hormones.
And
The medulla.
and where does it come from? From the mesoderm?
Exactly. The adrenal cortex develops from mesodermal tissue, while the medulla originates from neural crest cells, which are part of the ectoderm.
Interesting. And what does the yellow cortex and the brown medulla do? Where do they come from? Huh? Tell me, bro. Just a sec. Let me change the chat, guys. Pramo, so we're talking about suprarenal glands. Tell me again about the Tell me again about the yellow cortex, the brown medulla. Where are they? What they do? It's dying. Alright, guys, let's continue. So, yellow cortex, brown medulla, suprarenal glands. I've repeated myself 10 times. Could we talk about their location, what they do, what's the relations here?
Sure, let's break it down. The adrenal glands sit on top of each kidney. They have two main parts, the outer cortex and the inner medulla. The cortex produces hormones like cortisol and aldosterone, while the medulla releases adrenaline and noradrenaline. These hormones are crucial for stress responses, blood pressure, and metabolism.
What is the brown medulla and the yellow cortex, dude? I don't even understand.
No worries. The adrenal cortex and medulla are parts of the adrenal glands. The cortex is the outer layer, often shown in diagrams as yellow, and it produces steroid hormones like cortisol. The medulla in the center is typically shown as brown and makes adrenaline and noradrenaline. They're both important for regulating different body functions, especially in stress responses. You're welcome.
Alright, I'm gonna go forward. I think, guys, I read this thing in the past about basically it's funny. So about relationships, basically this book was saying, I think it's called it's a really good one, 7 Steps for Successful Marriage. I don't remember exactly the name, I'm sorry, but yeah, it was saying if your heart rate exceeds 100 in a conversation, just leave and come back in 15 to 30 minutes. I think this is what I should be doing when it comes to a topic, because then I'm gonna die of stress. Okay, having said that, let's continue with the course of the ureter in the abdomen.
Sure. The ureters are tubes that carry urine from the kidneys to the bladder. They start at the renal pelvis, travel down the back of the abdomen, crossing over the pelvic brim, and finally enter the bladder at an angle. This course helps prevent backflow of urine.
So it descends anterior to the psoas major muscle.
Exactly. The ureters descend anterior to the psoas major muscle. They follow the muscle down, cross over the iliac vessels, and then enter the pelvis. This positioning is important for both their function and surgical considerations.
And why, I don't understand why the psoas major muscle is, why does it descend anterior to the psoas major muscle? Is there a reason for it? What's the efficient, effective reason or whatever?
The positioning of the ureters is mostly anatomical convenience. By descending anterior to the psoas major muscle, they follow a direct path from the kidneys to the bladder while staying protected within the retroperitoneal space. It also helps them avoid major obstacles and structures.
Interesting. And so then it crosses anterior to the genitofemoral nerve, and I wonder why. Is it like, it's not luck? What's the reason?
The ureters cross anterior to the genitofemoral nerve due to their anatomical course. The nerve runs along the psoas major, so as the ureters descend, they naturally cross paths.
Well,
it's
why?
Not so much about...
Well, why then is this the case?
It's mostly just how our anatomy developed over time. The ureters take the most direct route from the kidneys to the bladder, and in doing so, they cross certain structures like the genitofemoral nerve. It's a result of how organs and nerves are arranged within the body.
Can you talk to me about the gonadal vessels and the bifurcation of the common iliac, please, artery?
Sure. The gonadal vessels, which are testicular or ovarian arteries and veins, descend from the abdominal aorta and run alongside the ureters. The bifurcation of the common iliac artery happens around the level of the pelvis, splitting into the internal and external iliac arteries. This is important because these vessels can be landmarks during surgeries.
Alright, so let's go again and think of the course of the ureter in the abdomen. If we can break it down to 8 steps, perhaps.
Sure, let's break it down. First, the ureters start at the renal pelvis. Then, they descend anterior to the psoas major muscle. Next, they cross the genitofemoral nerve. After that, they cross the iliac vessels.
So how many steps are those, ChatGPT?
We listed 5 steps, starting at the renal pelvis, descending along the psoas major, crossing the genitofemoral nerve, crossing the iliac vessels, and entering the bladder.
I'll be honest with you, this is such arbitrary information. If I don't put it into context, I might as well just put it in the dustbin.
I get that. Context definitely helps information stick. Maybe linking it to clinical scenarios, like why knowing the ureter's course matters in surgeries or with kidney stones.
Yeah, this is very important. Also, understanding why they are in that position is really cool too. If we could break down. So, descends anterior to psoas major muscle. Why?
Absolutely. The ureters descend anterior to the psoas major because it's a relatively safe, direct route that avoids other major organs and structures.
Why not
It also
posterior? Huh? Why not posterior, ChatGPT?
The ureter's anterior path helps avoid crowding near the spine and major vessels, reducing potential compression and ensuring a clear path to the bladder.
Alright guys, let's go back to arterial blood gases. So, can we talk a bit about mechano and irritant receptors in the lungs, please?
Sure, mechanoreceptors in the lungs, like stretch receptors, help regulate breathing. They respond to changes in lung volume, sending signals to the brain to adjust the breathing rate. This helps prevent overinflation of the lungs.
Okay, so from what I understand, we have C fiber. So we have C fiber nociceptors and mechanically sensitive receptors and lung stretch receptors.
Exactly. So C fiber nociceptors respond to chemical and thermal stimuli. Mechanically sensitive receptors respond to mechanical changes like stretch, and lung stretch receptors detect overinflation, helping regulate breathing.
Why do we call them C fiber nociceptors?
So the term C fiber refers to the type of nerve fiber. These are unmyelinated, meaning they don't have a myelin sheath, which makes them slower at conducting signals. Nociceptor means a sensory receptor for pain. So, C fiber nociceptors are slow conducting pain receptors.
Okay. And we have chemosensors too. We have central chemosensors and peripheral.
Exactly. Central chemoreceptors are in the brainstem, detecting changes in CO2 and pH in the cerebrospinal fluid. Peripheral chemoreceptors, like the carotid and aortic bodies, detect changes in blood oxygen, CO2, and pH. Both play crucial roles in regulating respiration.
And they detect it in the cerebrospinal fluid?
Yes, central chemoreceptors monitor CO2 and pH levels in cerebrospinal fluid, which reflects blood CO2 levels. When CO2 rises, it forms carbonic acid, lowering pH, which then triggers an increase in breathing to expel CO2.
Okay, can we talk about the two foci of peripheral chemoreceptors? Chemosensors, sorry.
Sure, peripheral chemoreceptors have two main foci, the carotid bodies and aortic bodies. The carotid bodies are located at the bifurcation of the common carotid arteries, while the aortic bodies are near the aortic arch. They both sense changes in blood oxygen, CO2, and pH, sending signals to adjust ventilation.
Interesting. That makes sense.
I'm glad it does. Peripheral chemoreceptors are fascinating because they're crucial for maintaining our body's balance, especially during changes like exercise or high altitude.
Yeah. Okay, let's go back to the ureter now. This is gonna be hard, and I don't want to leave it at the end or something. I wonder, because there's a lot of things that we haven't talked about the ureter, such as the course of the ureter in the pelvis, with the internal iliac artery, the ischial spine, and all of that, and so I'm just trying to find a way where my heart rate won't go up talking about this.
I get it. The anatomy of the ureters can be complex. Maybe breaking it into smaller sections could help. We could start with the course from the renal pelvis to the iliac artery.
The problem with this, I can memorize it. I just don't want to memorize it. I want to understand it. And this takes time, and it might annoy me a bit. And yeah, it would be good to find a way for it not to annoy me.
Totally understandable. Instead of memorizing, let's focus on the logical flow. Think of the ureter's path in relation to landmarks. It descends from the kidney, crosses over the psoas muscle.
I want to understand. I don't care about that. I want to understand the reason this happens. If I'm going to put anything in my brain, it's because I understood the reason that it happened, okay?
Absolutely. The ureter's course makes sense in relation to surrounding structures. It descends along the psoas muscle because that's a direct path from the kidney to the bladder, while crossing the iliac vessels at the pelvic brim aligns with the natural curvature of the body. Each step is about efficiently navigating the anatomy.
Well, okay. Why? Okay. So I'm going to break it in 8 steps, and I'm going to ask you questions sufficiently for each step, okay?
Sounds like a plan. Let's dive into step 1. What's your first question?
All right. My first question is, why does it descend anterior to the psoas major muscle and not posterior? Do not answer to me in an indirect way.
All right. The ureter descends anterior to the psoas major muscle because it follows the retroperitoneal space. This positioning allows it to take a direct path from the kidney to the bladder, while avoiding unnecessary obstructions.
And why does it cross anterior to the genitofemoral nerve?
It crosses anterior to the genitofemoral nerve because the nerve runs along the psoas muscle, while the ureter has to stay close to the posterior abdominal wall. This arrangement ensures the ureter follows a smooth, unobstructed course to the bladder.
Now, why is it obliquely crossed by the gonadal vessels?
The gonadal vessels cross the ureter obliquely because they originate from the aorta and travel down to the pelvis. This diagonal path intersects the ureter, which runs vertically.
So what?
So, this crossing happens naturally as both structures follow their own paths from their origins to their destinations.
And then it crosses the bifurcation of the common iliac artery to enter the pelvis?
Yes, exactly. The ureter crosses the common iliac artery bifurcation because it needs to enter the pelvis. This spot is a natural landmark where the ureter transitions from the abdomen into the pelvic region.
Why is it called iliac?
It's called the iliac artery because it supplies blood to the iliac region, named after the ilium, the largest bone in the pelvis. The bifurcation is where the aorta splits into the common iliac arteries.
And why does it go downward in front of the internal iliac artery and not the external?
The ureter passes in front of the internal iliac artery because it heads toward the bladder, which is located in the true pelvis. The external iliac artery stays more lateral, and continues towards the lower limb, so the ureter naturally crosses the internal branch.
Interesting. And then it turns forward and medially, and I don't understand why.
It turns forward and medially to reach the bladder, which is positioned in the midline of the pelvis. This final course ensures a smooth entry into the bladder from above and slightly behind.
Alright. Can we talk a bit about ureteric constrictions?
Sure, ureteric constrictions are narrow points along the ureter. There are three main sites where the renal pelvis narrows, at the pelvic brim near the iliac vessels, and where it enters the bladder. These are potential sites for kidney stone obstruction.
Tell me again about ureteric constrictions. What even is this?
Ureteric constrictions are specific points along the ureter where it naturally narrows. These constrictions are important because they're common sites where kidney stones can get stuck, potentially causing pain or obstruction. The three main constriction sites are where the ureter exits the kidney, crosses the pelvic brim, and enters the bladder.
So what is this uretero-pelvic junction?
The uretopelvic junction, or UPJ, is where the renal pelvis transitions into the ureter. It's the first constriction point and can be a site for kidney stone obstruction or congenital narrowing.
Interesting. And the crossing of the common iliac artery also is a constriction possible?
Yes, the crossing of the common iliac artery is the second constriction point. The ureter is compressed as it crosses over the artery, making it a spot where stones can get stuck.
So what are these ureteric calculi? I don't know.
Ureteric calculi, or ureteral stones, are kidney stones that have moved into the ureter. They can cause significant pain, known as renal colic, and may obstruct urine flow, requiring medical intervention if they don't pass on their own.
Okay, and can we talk a bit about the arterial supply of the kidneys?
Sure. The kidneys primarily receive blood from the renal arteries, which branch directly off the abdominal aorta. Each kidney typically has one renal artery, but variations can exist. These arteries further divide into segmental, interlobar, arcuate, and interlobular arteries, ensuring the kidneys receive a rich blood supply.
And I was going to ask, what are all these different types?
So the different types of renal arteries serve specific regions. Segmental arteries branch from the main renal artery, supplying different kidney segments. These split into interlobar arteries, running between the renal pyramids. Arcuate arteries curve over the pyramid basis, and interlobular arteries extend into the cortex, forming afferent arterioles that lead to the glomeruli.
So what's the difference between interlobular and interlobal?
Interlobar arteries run between the renal pyramids, while interlobular arteries branch off the arcuate arteries into the cortex. Essentially, interlobar vessels are larger and deeper, while interlobular vessels are smaller and extend to the kidney's outer regions.
Okay. Can we talk about the blood supply in the suprarenal gland in the kidney then?
Sure. The suprarenal glands, or adrenal glands, have a rich blood supply. They receive blood from three main sources: the superior suprarenal arteries from the inferior phrenic arteries, the middle suprarenal arteries from the aorta, and the inferior suprarenal arteries from the renal arteries. The kidneys are primarily supplied by the renal arteries, as we discussed earlier.
Interesting. So can we talk a bit about the right suprarenal vein and the left and the renal vein and the gonadal vein and all of these? Mesenteric artery, superior.
Absolutely. The right suprarenal vein drains directly into the inferior vena cava, while the left suprarenal vein drains into the left renal vein. Similarly, the left gonadal vein also drains into the left renal vein, whereas the right gonadal vein drains directly into the inferior vena cava. The superior mesenteric artery supplies blood to the midgut, while the inferior mesenteric artery supplies the hindgut.
Okay. Thanks for watching, guys. I shall see you next time.